Welcome to the Fibromyalgia Podcast. I'm Tammy Stacklehouse, fibromyalgia coach, author, and founder of the International Fibromyalgia Coaching Institute. The goal of this podcast is to empower you with access to the dream team of experts and coaches I've discovered are key to living the fibro life you love. From the comfort of your own home, and maybe even your pajamas, I'll help you take back control of your life and health. To help out with fibro fog, I always include full show notes and additional resources at fibromyalgiapodcast.com. Welcome to the Fibromyalgia Podcast. I'm your coach, Tammy Stacklehouse, and this is episode 175. Today, we're talking about something many fibromyalgia patients live with every day, even if no one has ever named it: an overactive stress response driven by an out-of-balance autonomic nervous system. My guest today is Dr. Andrew Holman. After treating thousands of fibromyalgia patients over several decades, Dr. Holman noticed clear, consistent patterns, not just in pain, but in sleep, sensitivity, recovery, and treatment response. Many of his patients were stuck in fight or flight, leading to disruptions in deep restorative sleep and pain amplification, even when the right treatments were in place. Today, we'll explore what this means for you and your fibromyalgia, how the nervous system affects pain, sleep, and energy, how tools like HRV make the invisible visible, and why this information can be empowering rather than overwhelming. Now, let me introduce you to our guest. Dr. Andrew Holman is a board-certified rheumatologist with 25 years of clinical experience. Through his work treating thousands of fibromyalgia and autoimmune patients, he became deeply interested in how stress biology and autonomic nervous system imbalance affect healing. He is the co-founder of InMedix, the company behind Cloud HRV, an FDA-approved technology that measures autonomic nervous system activity through heart rate variability, or HRV. This happens in just 5 minutes in a clinical setting. In clinical research, incorporating autonomic nervous system balance into care was associated with a dramatic improvement in outcomes, increasing remission rates in rheumatology from 25% to 79%, and helping shift care away from trial and error and towards more precise, individualized treatment. And yes, I do talk to him about those numbers in our interview today. As always, I want to remind you that the information shared in this podcast is for educational purposes only and should not be considered medical advice, nor is it a substitute for working with your own healthcare provider. Now, that said, Dr. Holman has put together a list of resources you can download and share with your doctor. You'll find those linked in today's show notes at fibromyalgiapodcast.com/175. And be sure to stick around after the interview. I'll be sharing a few additional insights and some resources based on what we discuss in the interview today. Now, here is my conversation with Dr. Andrew Holman. Welcome to the podcast, Dr. Holman. It's so good to have you here, and I've been so looking forward to this conversation.
Me too. Thanks very much. It's an honor to be here.
Yes. Now, I always like to start with what got you here. So I know you have worked with fibromyalgia patients. You've done a lot of things with fibromyalgia. Was that just sort of part of what you did as a rheumatologist, or did you have a real specific interest in fibro?
I'd say I had a pretty strong interest in fibromyalgia. I'm a Seattle guy, trained everywhere else, but came back to the University of Washington for my rheumatology fellowship, and I finished in 1992. And we had a wonderful woman there named Jan Hilson. She's still a rheumatologist, who was taking fibromyalgia seriously, but she was out on an island by herself. And I was impressed with the level of kindness, but also the level of curiosity. Like, what could this possibly be? Rheumatology, as most people know, is the study of autoimmune disease. And autoimmune diseases have been puzzles, and we're pretty much detectives, to be honest with you. And what turned out to drive most of our diseases was the immune system. So attacking various tissues, rheumatoid arthritis, lupus, ankylosing spondylitis, so forth. But fibromyalgia was thrown into the board exam thinking it might go that way, and it was a different approach entirely that was required to answer it. So again, a puzzle. I became the main rheumatologist at Valley Medical Center in South Seattle in 1992, and I was there about 20 years. Basically, I didn't know what to do either, but I was interested, and I thought it was our responsibility as rheumatologists. So I worked every day, 5 days a week, and I saw 3 to 4 new patients with fibromyalgia every day and about 10 follow-ups for about 15, 17 years. Very busy practice with autoimmune disease in terms of rheumatoid arthritis and those types, and psoriatic arthritis. So classic rheumatology, but a strong emphasis on fibromyalgia, just like Steve Overman did, and Phil Meese did, and Rich Jimenez does today. And there are more private doctors in Seattle interested in fibromyalgia than probably anywhere that I could think of. Although you and I talked about Oregon, Rob Bennett was at the University of Oregon, really the head, the leader, the academic leader of the Pacific Northwest. So all those people really got me interested. Like, what could this possibly be?
That's awesome. And that is a lot of fibro patients and things coming through your door there. I bet you would just naturally start seeing patterns, thinking, I think I see some things that are happening here. What sort of jumped out at you as somebody who was seeing all these patients, like commonalities, causes, things like that?
There's a number of things that we know are very relevant today, and it took time to sort of sift it through. And when I teach young doctors, I tell them patients tell the truth. So don't give me this about somebody who's trying to embellish with this. They tell you the truth that they can know. They tell you as best they can. They didn't go to medical school. And sometimes it makes sense, sometimes it doesn't, but it's your job to make sense of it. But they're telling you the truth. And I had a few people, okay, maybe not, but 99% yes. So it starts with that. The next one is it's not nothing. Doctors say, oh, no, it's not life-threatening. It's not, it's just not nothing. No, it's never nothing. It's very important. It's something. It's got to be something. So as long as you believe patients tell the truth and it's got to be something, then the question is, are you going to take responsibility and work on it or not? So as you listen to patients, first of all, you see a large predominance of women, and that's not uncommon. A lot of women get autoimmune disease, even though it's not the same. You see a tremendous emphasis on sleep problems, and not just the lack of sleep, but non-restorative sleep, which is a very important concept. We called it classification criteria when I was a fellow, which is not the same as diagnostic, technically from an academic point of view, but it's semantics mostly. But it relied on these things called tender points, these 18 tender points. Now, this is back in the 90s, right? And so why would somebody have exaggerated, more intense, amplified tenderness? Tenderness and pain are different things. Pain is pain without touching. Tenderness is pain with touching. So that was curious. And then other things would be more painful too. So if they had GI distress, or they got a gout attack, or they broke their toe, or it just hurt a lot more. So it's like, what's going on here? So that's important. The other thing that was an interesting early observation, at least in the first 5 years, was that patients with fibromyalgia seem to have Ehlers-Danlos type 3, or what we call hypermobility type now. What we do with diseases, if we don't know what to do with them, we change the names. So, but it's still EDS3 in my world. Now, EDS3 can be a horrible joint laxity problem that leads to all kinds of dysautonomic things, and we'll get into the autonomic nervous system. But it's very interesting that when they were not as stiff and sore and in pain, they were pretty flexible. They did dance, gymnastics, they have kids that bend all over, and we'd see other people with hypermobility. And they just seemed to get more of this autonomic stuff going on. And then in 1998 was really the breakthrough out of Mexico City. Martinez Levine reported that the use of heart rate variability, which we'll go into, at night demonstrated that their fight or flight response, particularly the gas part of the autonomic nervous system, was more active compared to other controls between midnight and 4 a.m.
Specifically that time frame.
Yeah. Yeah. So what's going on there? And then later came the cervical spinal cord, which I look forward to going into because not many people know about that part. So yes, we're seeing patterns. We're seeing patterns. And the one thing where I'm absolutely convinced about is that nobody's checking their notes before they get to see me to make sure they all have the same story. That's just ludicrous. That's not going on.
Right.
So,
Oh my goodness.
so
Yeah.
lots of patterns, lots of patterns.
Yeah. Which just, if anyone's listening to this and you've heard, the fibromyalgia isn't real thing, like that just adds more weight to the, yes, this is real. You wouldn't see patterns if people were making it up. And like you said, all of us can't be checking our notes with each other to tell you the same story.
The other thing to recall for those of you, if you're around clinicians who believe it's not real, which is really outdated now, but back in the 90s, it was more common than not, is that the FDA does not approve drugs for diseases that don't exist. There are 3 FDA approved drugs. None of them are what we all hope for, but the FDA does not approve drugs for diseases that don't exist. So anybody gives you that, that's what you tell them, and then you go find another doctor.
Which is a whole nother podcast episode.
How do you find a good doctor?
Yes, yes. So before we move away from all of this, and this might be a whole nother podcast episode too, but this question of whether fibromyalgia is autoimmune or not.
Yeah. It depends who you talk to. If you talk to 90% of people who read the literature as much as I and others do, they'll say, no, it's not. But there are things that can make you think, well, maybe I. Rheumatologists are bona fide experts in the immune system. We are medicine's immunologists. So we understand inflammation, cytokines, T cells, B cells, it goes on and on. It's what we do to the mouse and molecular and genetic level. That's our expertise. There's compelling evidence that fibromyalgia is really constructed, and I'll just put it in a nutshell for you right now. Harvey Moldavsky, 1995. I believe that reading his papers, he actually caused fibromyalgia in 4 nights in college kids in Toronto by depriving them of the stage 4, 3, and 4 deep sleep, and I'll explain what that is. In 4 nights, you couldn't touch them. They're ached all over. They're complaining, and they said, let me out of here. And in 2 days, since their brains were able to sleep deeply, they recovered. Did the same thing in ROTC equivalent recruits in Canada, and it didn't happen. So there's something about fitness that was protective, but not therapeutic necessarily. And you'll have people argue about that. So it looks like this is what happens when you torture people by sleep deprivation. But I've never been to the CIA. I've never talked to those people. I've never been to, regimes in Central America. I don't know where they torture people. But those who are in the know probably realize that if you sleep deprive somebody, it amplifies pain. I don't mean to put it crudely, but if you hit them with a rubber hose, it hurts a lot more. So maybe so bottom line is you need your deep restorative sleep. We know that it's when you make growth hormone. We know that it's when you restore muscle function. It's particularly well studied in athletes who need high performance. They need that deep sleep to have a body function properly. And of course, cognition and fatigue is all wrapped up in it. The question is, what did Moldavsky do when he played that irritating noise in the middle of the night while they were sleeping with the EEG on? As they're going to deep sleep, he played this noise. They startled him into light sleep, and he'd go back into deep sleep, did it again. After the 4th night, he had to play the noise almost all the time because the brain was so trying to get back into deep sleep. Well, it's done with the experiment. It goes into deep sleep. They recover. Here's Martinez-Levine, the autonomic nervous system. The autonomic nervous system is your command and control center in your brain that controls all your housekeeping functions. There are 2 parts, the sympathetic, which is kind of like the gas, fight or flight. We all know what that feels like. And the parasympathetic, the opposite, rest and restorative, that predominates during deep sleep, and sympathetic predominates when the bear's chasing you. And then life is maybe in the middle, or maybe not so much. Maybe it's more like the bear all the time. The question is then understanding how sleep works. And I don't mean to digress, but let's make sure your audience kind of gets us a nutshell, then we can dig in. Alarm clock. It doesn't wake you up. What an alarm clock does is it activates your fight or flight response and startles you, and that's the part of the brain that wakes you up. Okay? The baby crying doesn't wake you up. It's the alarm of the baby crying that wakes you up. Same with smoke, same with idea. So my thinking at the time in the 90s was, okay, we need these people to get deep sleep again. Maybe we'll try to let them sleep instead of trying to make them sleep. Just different philosophical approach entirely. Like you would for a small child who has a nightmare. You kind of hug them and make them feel better. And what are you doing? You're calming them down. You're not putting them to sleep. You're calming them down to allow them to drift into sleep. It's really pretty logical. And having children in the 90s actually helped a lot too, as a doctor.
Yeah.
Just to understand. Because again, I have a whole family of hypermobile people. Anybody who can do this. Well, I know the audience can't see that. But EDS3 is really common. And those people have an increased sympathetic response that can be extremely powerful and sometimes not turn off. And then what comes after that is the spinal cord, which we'll go into later. But the whole idea here was trying to understand how sleep, what it does for you restoratively, cognitively, muscle-wise, and sensory-wise. And then understanding that it was caused experimentally. And then understanding the triggers the autonomic nervous system, most likely. And many things can turn on the autonomic nervous system, which took me from rheumatology and immunology and fibromyalgia to neurology. With the autonomic nervous system is the purview of neurologists. They just don't do much with it. We all get about a day and a half in med school. That's all we get. But it turns out it's the most fundamental part of your brain. So that's a lot for everybody here. Happy to go into the pieces and parts. But I wanted to make sure before anybody gets sleepy, listen to the podcast, that they got the most important part. You need to sleep normally. You need to understand the autonomic nervous system. You need to understand what turns it on. And you need to how to activate the parasympathetic so you can just go to sleep and get your rest and come out the other side without fibromyalgia, which is not an overstatement.
No, and a whole lot easier to say than to do, right?
Yes, but there are people who blaze the trail already. And I'll make sure people understand. This is peer-reviewed literature evidence that I'm trying to share with you.
Absolutely. And so I think now would be a great place to talk about how we measure that response. There's the experiential measure of it, right? Like I'm stressed out, I'm anxious, I can't fall asleep. But you can also measure that.
Yes, you can. And if you don't measure things, it's hard to manage them.
That's right. That's right.
So again, I had to learn all this. And we got little snippets. It starts with something called heart rate variability, or HRV, which the world is learning about with the fitness trackers, Apple, Oura Ring, Garmin, Whoop, who am I forgetting? Fitbit, Polar. Polar's a little more for athletes, but it's on the news. You hear all about it. Personally, I keep an eye on Whoop because I think they're a very exciting company. I actually have one on my wrist. I compare theirs to our technology all the time. What people don't realize, and I didn't realize until someone taught me, is that you can't measure the autonomic nervous system directly very well. We know about cortisol. Cortisol is a hormone that makes the stress hormone, we call it sometimes, goes up with stress. But it's a very blunt instrument. The autonomic nervous system, the central brain, which has the sympathetic and parasympathetic halves, integrates with the endocrine system. They work together to manage whatever comes your way. Dehydration, infection, cancer, what virus, doesn't matter. The autonomic nervous system is there to respond and to maintain what we call your homeostasis. And when it works, great, you don't think about it. When it doesn't work well, you notice all kinds of things. But you can't measure it directly. And the endocrine system works in minutes to hours to days, and the autonomic works in milliseconds. But we know more about the endocrine because we've been able to measure it all this time. Now what's happening with the HRV become more popular is we realize that there are methodologies that can look at heart rate variability. So let's explain what that is. Heart rate variability is looking at how your brain manages your cardiac rhythm at rest. That's simple. So if you are sitting in a chair and someone takes your pulse and it's 60, you actually don't have a heartbeat every second. You have a heartbeat at 1.1 seconds for a while, then 0.9 seconds, and 0.1 and 0.9. So it varies. That's what's called heart rate variability. It's a normal physiology. But what was discovered many decades ago is that if you put someone under significant stress, that rhythm becomes a metronome and you lose all the variability. So it turns out it's an indirect measure of the autonomic nervous system stress response. And what comes of it is all kinds of exotic mathematical analyses and formulas to actually look at the timing between beats. So you have to know where the beat is, which takes some hardware, and then you have to have the right math. And people can look under their ring The green light underneath, that's called photoplethysmography. It's very convenient. It looks at the pulse rate. It can actually do AFib and all kinds of other things. It's a little bit of a challenge for it to actually pinpoint the heartbeat with such precision to measure millisecond differences between beats. But it's a good start, and it has value. To get medical grade, to get through FDA, you need to have an actual EKG that looks at the spike, the QRS spike, as opposed to the waveform of the photoplethysmography. So you have to have an EKG. There is no precise wrist EKG test. There's no technology yet. Now, there will be very soon because people are going to see why it's important. So we use a limb lead, wrists and ankles, so no chest leads, got rid of all that. Lie on a table, 5 minutes, and you get about 350 beats to beat timings, goes up to the cloud, and we have added features in our proprietary heart rate variability software that actually can then, in 10 seconds, tell the doctor in the office, what's your sympathetic, what's your parasympathetic at rest. And that is the big excitement that drives my day. So a next step, next generation of heart rate variability to exquisite medical precision based on prospective double-blind studies.
Yeah, yeah. And, I have played around with this a little bit using both heart rate variability, and actually it was a client of mine that taught me the old runner's trick of your morning resting heart rate. And if your morning heart rate goes up, you've overtrained, and then applying that to just doing too much with fibromyalgia. I mean, it could just be that you sat upright for a little longer. And that was overtraining. But this idea of something that's a lot more granular, a lot more specific to really drive medical decisions, not just is today a rest day or not.
And resting pulse is actually a marker of sympathetic fight or flight autonomic state. So resting pulse, we have patients that are walking around resting pulse. The best they ever do is 85. And we worry about them versus someone 60 or someone comes in at 50. We actually pay attention to that as physicians. Now we're at the next step where we're more granular, as you say. We have the opportunity to dig in deeper, to actually look at both components of the autonomic. What the old HRV, which was codified in 1996, called time and frequency domain, for those really digging in, it never had a sympathetic measure, the fight or flight part. It has a parasympathetic, two of them. RMSSD, which is what Whoop and Oura Ring and Apple and Fitbit all use. That's what they're using, that math. And something called high frequency. So again, we can get all kinds of fun math and stuff, but I don't want to scare people. But it's the next generation of mathematics that we found in clinical trials provide the precision we need to measure both parts. And that's how it got through FDA.
Nice, nice. So one of the things that I will be using it when I record our introduction is the results that you saw with getting patients into remission, tripling that 25% to 79%. Talk about that a little bit, because I personally love the math, and especially when you have data, that makes you sit up and take notice.
Yeah, it's about clinical, it's all about, you talking to your patient and what can you do for them. Now, I have to be careful because we're a highly regulated company. So our technology is not FDA cleared to do what we're about to talk about, but I'm talking about peer review studies based on the technology. So the first is important. Before I get into what you do, we did a prospective double-blind study in patients with rheumatoid arthritis. So it's not fibromyalgia. Fibromyalgia was excluded, actually, because it can come together with rheumatoid arthritis about 30% of the time. So we excluded that so it wouldn't confuse us. And we simply said, does the autonomic nervous system and its influence on the immune system that the NIH was starting to talk about and so forth 25 years ago, is this advanced version of HRV relevant to predict who would respond to treatment of rheumatoid arthritis? Now, again, it's not FDA cleared for this, but the study showed that this technology predicted a year in advance who would respond to the biologic treatment for rheumatoid arthritis. So that shows associative. Doesn't mean it's causal, but it was suggesting it's associative. Other people were then looking at things called vagus nerve stimulation, which just got FDA cleared for rheumatoid arthritis in June. People go to the front page of, I think it's August 1st, New York Times. literally front page, and to try to increase the parasympathetic so that the sympathetic, its opposite, is not predominating and driving inflammation to make rheumatoid arthritis untreatable. They're going to Crohn's disease and MS and all kinds of stuff. And kudos to them for working on that. I was interested in balance of the autonomic nervous system within the brain, theoretically, rather than hijacking the vagus nerve, because I need people to sleep and I need that sympathetic drive to come down. We learned in fibromyalgia, and again, it's not proof for that, but we learned that if you look at restless leg treatments, and nobody really knew what that kicking business was until more recently, because it wasn't life-threatening, so it didn't get a lot of research money. But we found that if you turned off the kicking, you had a better shot at getting a fibromyalgia patient to sleep better on other things. So again, we were thinking it might just be a sympathetic explanation for that. So we didn't know. But at the time, we had noticed that when we treat fibromyalgia with rheumatoid arthritis in other patients, that if we were making progress on the fibromyalgia, the rheumatoid arthritis treatment was getting better. So there was this linkage, right? So it took paying attention to fibromyalgia to make this advance in autoimmune disease. And if
That's
you weren't
awesome.
going to see fibromyalgia, you missed the boat entirely. So, so I feel very grateful to all those patients. We looked at 60 patients who had rheumatoid arthritis without fibromyalgia. They were advancing to Enbrel, which is etanercept. It's an Amgen biologic leader to treat rheumatoid arthritis. Been around since 1998. And that was just their first treatment. And there were 60 of them. And the problem in my field is that with any treatment I have, it's only 25% remission or disease control. Can I get on any of these, what are there, 14 or so more ways to block the immune system? Very expensive biologics, complicated things. But I go at 25%. We were able to get disease control by combining an autonomic sort of optimization approach, theoretically, with the Enbrel to 79%. And more important than that, because people are tough as nails, they'll live with the pain. You know how that is. But they were able to get off steroids, which they really liked, about 62% of the time. And 75% of that cohort was able to discontinue their weekly methotrexate, which means these are women of childbearing age very often. And if they wish to, they could have children again, otherwise they couldn't. So the idea of what we call immunoautonomics, combining an autonomic therapeutic, not just for fibromyalgia, but for the immune system, with our treatment combined was a big step in the right direction, we believe. It's led to all kinds of research to maybe look at these diseases a little broader.
Yes. And I'm thinking, as you're talking about that is probably true across the board, like not just rheumatology.
Very compelling to wonder about that. Yeah. We've got our hopes and aspirations in that same direction. Yeah.
And I mean, it makes sense from just a common sense perspective, right? If you're running for your life because the bear is chasing you, things aren't important and other things are, right?
And sleep is not one of them.
Right.
and pain doesn't matter because you got to run for the bear. You hear these stories in war that people get shot in the leg and they run a mile before they notice they were shot. I mean, that's got to hurt, right? You hear the story of the mother picking the carp off the baby. I don't know, but you hear the stories and you think there's something really special about this fight or flight response. But it's two sides of a coin. So the bottom line is that we know it matters. And it all came from making sense as best we could from people with the most puzzling presentation we call fibromyalgia.
Yay, us.
It is a tremendous contribution to medical advances that the fibromyalgia patients just didn't give up.
That's right.
So I'll just tell you that.
That's right. That's right. So what do we do with this information? I mean, obviously you went out and you founded a company and made all these things, but from a patient perspective, what do we do with this information?
I found that in Seattle, we were getting a very favorable response rates in the office in Renton, where I was the main rheumatologist. So then I wrote papers and did studies that even I paid for just myself, without grants. And that probably touched a few more lives, right? But not very many. And then we thought, well, I've been exposed to this technology. I just happened to know somebody who said, these sports guys are looking at stress. I think you ought to take a look. And I got a chance to borrow it. So I did 9 studies. This is back 2001 to 2007. I actually retired because I sold patents to Boehringer Ingelheim because I discovered how dopamine agonists treated fibromyalgia, did a randomized controlled trial on my own nickel, and we sold them the patents. So I got to chase my kids around from 45 on. But we had this patent on the use of autonomic optimization to improve outcomes in autoimmune disease. And to be honest with you, it was just ahead of its time. And because we were really expecting a better immunologic answer. We had a couple on the market. We thought, well, the next one will be better, next one will be better, next one will be better. Turns out that by 2015, the world they need to have some help. This ceiling effect was so obvious in the autoimmune diseases. We said, okay, let's go to that company who does this in sports and ask for the license, and let's take it through the FDA and go through all the work for safety and efficacy, and then bring it on the market. We got FDA cleared in January, and then we had the first 5 in a soft launch. We found that it's robustly reimbursed in 4 states in the United States. It's really easy. You don't need a special room. You don't need a special trained staff. They have to follow the instructions, of course. But it's simply 5 minutes supine right after you get your blood pressure checked. It's right when you usually scroll your phone when they say the doctor will be right in. You go, okay, how many? Yeah, I can check a lot of emails. Yeah, no, we use that time, so it seamlessly integrates. Doctor gets paid to do it. We get paid to do it, and then the doctor uses that to make decisions. It's their choice on the relevance of your autonomic nervous system for whatever they're treating, and then things that might optimize it, which includes all wellness opportunities, Tai Chi, meditation, diet, exercise. These are all things that are all designed to improve autonomic state. There are medications and stuff, none are FDA approved for it. But all this research is coming. And now vagus nerve stimulation is. So what will happen in May-ish is we expect to have the first 50 of the second 50. We had first 5, but the next 50 of these things we call cloud HRV going out to physicians so you can have it in the office. And we realize that's woefully too low. So we're raising funds to actually build more. It's very exciting. We have a waiting list of over 200 doctors already without marketing any of it, based on just the clinical trials and medical meetings and the interest in how stress might affect rheumatology and maybe cardiology and maybe GI and maybe sleep and certainly fibromyalgia and chronic pain. And there are people that describe this as a missing vital sign. I don't know if I can argue against that, but I want to make sure that you realize the FDA says this is cleared to be an HRV diagnostic for which the doctor uses their discretion. So it's not HRV for rheumatology, it's not HRV for cardiology, it's not HRV to use that drug, this drug, whatever. It's to understand the autonomic nervous system, and then the doctor takes over from there. We will be doing research, obviously, for more specific intended uses, right? We'd like to see, point out the prediction, point out the treatment, do all that. But as we stand at a very early company, just need to be very clear that we're trying to get this in doctors' offices so they can use this to follow their own reasoning on how does stress affect health.
Yeah. Yeah. I love that. I love that. And to help you, like, for instance, which clients or patients are going to respond better? Like, who is meditation going to help the most? Or, those kinds of things. Like maybe there's somebody that is less important for. So you're actually able to give more individualized.
Well, you were in Seattle, right?
Yeah.
So Seattle is kind of east meets west, and we're very progressive and hopeful. When I give grand rounds at the University of Washington, it's very different than when I give grand rounds in Eastern City.
Yes, I bet.
And in Eastern City, I have a lot of mouse pathology slides and those kinds of things because that's what they want. In the West, it's more aspirational. What do you think you can do? And we're just as rigorous scientifically. But there's more like, well, what about Tai Chi, meditation, acupuncture? What about all, what about, we tend not to throw stones too quick, because we're open-minded. We try to be more learn-it-alls rather than know-it-alls. I mean, we try, it's hard not to. So basically, if a patient would come to me and say, okay, geez, doc, you got me on weekly methotrexate. It was a chemotherapy. Got me on steroids. Okay, I can tie my shoes now, but I put on 20 pounds. I'm not happy about that. And now you want me to give a shot every week with this biologic costs $50,000, which, is immunosuppressive. These are dangerous treatments, but we try to manage them safely. And now you want me to do what? can I just do something without a pill? And the answer now, because we can measure the autonomic nervous system, is yes, you can. You always could. But let me give you an analogy. You're diagnosed with hypertension. The first thing you say is, okay, I promise to cut back my salt and lose some weight. Don't put me on a pill. Okay. But you're coming back in 6 weeks and we're measuring your blood pressure again, right? So now we can monitor your autonomic state. So hopefully there are people who have natural skills, and maybe the teachers can teach them well to do non-pharmaceutical ways of managing autonomic state. And then some folks try as hard as they can, and I just can't run faster. I'm trying. It's not a matter of effort. And then as your doctor, I'm still responsible to help you get to where you need to be, which is a balanced autonomic state, right? It doesn't harm you. There's no bear.
That's right. That's right. So that's actually, I think, perhaps a good distinction. Like, are we trying to, I realize these are probably the same thing, but it might just be semantics, but are we trying to improve heart rate variability, or are we trying to balance the autonomic nervous system?
It's the same thing. When you lose heart rate variability, when you lose the variability, you have a higher sympathetic activity and lower parasympathetic, because now we measure both parts, right? When you balance it, you tend to bring them more to equilibrium, which then restores that variability. And in journal articles, that's a very positive thing for human physiology. Again, the autonomic nervous system does not cause everything, but it plays a role, and it affects my performance as a physician. If I'm trying to help you and your sympathetic activity is either naturally genetically high and life maybe cranks it up some more, I struggle to help you. Anyone could understand if you're trying to treat hypertension, high blood pressure, and someone's under terrible stress. Imagine what the doctor's trying to come up with to block both. Now that people can manage their blood sugar and monitor it on their phone continuously, they all know that stress makes the blood pressure go up, even though they didn't even eat. We all know that. You don't need that, raising your blood pressure and increasing your hemoglobin A1C and all the consequences of that. So that's a very logical opportunity. So basically, it's just a way of measuring what we all know matters already. But the difference is the remarkable, exquisite mathematical precision that was not available before, and really was a secret sauce for winning gold medals, gold cups, and NFL Super Bowls. That's where this technology actually comes from. It comes from professional sports, and the reason you never heard about it because it's a secret. Nobody wants to tell. The Seattle Seahawks, I understand, during the Super Bowl years, they use this technology. But I don't think they want the 49ers to use it. I mean, you know what I'm saying? It's very interesting. It's a completely different application, but stress responses are very important for human performance training, which is why there's such a sports emphasis for these fitness trackers, right?
Right. Absolutely. Absolutely. Now, you just briefly mentioned something that you and I talked about before we started recording that I want to revisit specifically for Brenda. Hello, Brenda. And that is this idea that some people just aren't going to be able to increase heart rate variability in the same way that maybe other people could easily increase it. So can we talk about that just for a sec?
I can't quote you a paper, but just from being a practicing clinician, it's not fair. People do everything right and bad stuff happens to them. People do everything wrong and nothing happens to them. And then we got a lot in the middle. It's not always a matter of effort. We don't understand why exactly, but it's nobody's fault. The key is if it doesn't work out, turn to your physician and put them to work and say, get me some results. Because that's what's coming. It's like, if your blood pressure doesn't come down with a couple of choices and salt and lose 20 pounds, you still go to your doctor and say, we need to do something so I don't have a stroke or a heart attack. And the doctor understands that. We're getting the same way with the autonomic nervous system. So no one should feel guilty. I had a wonderful teacher who said, if you go to the barber, you're probably going to get a haircut. If you go to the doctor, they're probably going to want to give you a prescription. That's not necessarily what we're supposed to be doing all the time, but you're going to get some kind of therapeutic something. And of course, fibromyalgia patients have lived with, well, it's nothing, we're giving you nothing and don't come back. We're not doing that anymore. We're going to take it seriously and do something for you. So it's a whole new world called autonomics. And it's really a new specialty in medicine. It's neurology, but it really is more than that. It's human physiology. One of my first investors, a very famous internist from South King County, and he said, this is his quote, that autonomics to this century will be what infectious disease was to the last. So back in the 1920s, 30s, the first sulfa drugs, and then later penicillin, and then some more. I mean, infectious disease really took off. Antivirals, it was quite a century for treating viruses, bacteria, protozoas, funguses. It's really important. People would just die before, right? And now they have fighting chance. The autonomic nervous system may well be. He might be right. He might be right.
Yeah, well, it certainly is a big buzz right now, I mean, just from a social
People know more
standpoint.
about it than I thought. I've been in my bubble, right? I live in a bubble. I'm a doctor.
That's right. That's right. So let's talk about like what are some of the things that people can do? Because this is one of those worlds, like there may be medications, but the majority of the things really are things we can do for ourselves to help calm down that nervous system, right?
Yeah, I spent my career in Seattle working with naturopathic doctors, Bastille, all kinds of people. We're a big team. And I was more the drug person, obviously. But there's all kinds of things. And I can't speak to randomized controlled trials of other things. But the one thing that struck me with the autonomic nervous system is to avoid missing something else you have that drives the problem.
Yes.
Fibromyalgia is a very good example. If you have fibromyalgia, you by definition have high sympathetic tone. And that sympathetic tone will drive your pro-inflammatory cytokines, which leads to this observation that if you measure immune markers in fibromyalgia, they're higher, hence it's an autoimmune disease. My humble opinion is it's an epiphenomenon. It's not really, it's not like it's not true, but let's see what the autonomic part is doing to your immune system.
Cause and effect, right? Like it's the symptom, not the cause.
Yeah, it's like if you were in terrible distress and your pulse was up and your blood pressure was up, I think I'd treat your distress first and then see if your cardiovascular comes down. That would be my inclination. So the one thing you want to never miss, and this is more important for autoimmune disease than fibromyalgia so much, but never miss sleep apnea. Never, never, never.
Yes.
Patients with rheumatoid arthritis don't die of joint disease, they die of heart disease. And they have an increased risk of cardiovascular disease that for 20 years was just a big mystery. And some people jumped to the conclusion there was inflammation of the joints, must be inflammation of the heart. That was a chasm that probably didn't bridge very well. In Japan, they published, mostly Japanese women, study that 53% prevalence of sleep apnea in Japanese women with rheumatoid arthritis who didn't snore, weren't heavy, weren't tired, had nothing to tell you. And how they got that study paid for, I have no idea, because it's like, let's just go see. It was like 95 patients they paid for. And then they did something fascinating. This was 2003, by the way. They treated the sleep apnea with the CPAP, right? They were able to tolerate it, which is not so easy, but they were able to. And that restored their oxygen and gradually turned off the fight or flight response, which is the response to low oxygen. That's why it's on, because it makes you breathe. The alarm is going down over about 5 months, which is about how long it takes for your heart disease risk to go down to normal if you treat sleep apnea effectively. Well, guess what happened to the swollen tender joint and inflammatory markers? They went down 35% in 5 months.
Without changing anything
Without
else,
changing
just the
anything.
CPAP machine.
That's a beautiful example of treating an autonomic cofactor or comorbidity, we would call it, which needs to be treated anyway to not get heart disease. And look what it did to the immune system. That was compelling evidence. So one is never miss sleep apnea. I wish I could tell you that treating sleep apnea and fibromyalgia was always effective. It is very rarely is. But it's at least you don't want to die of heart disease. But if you have an autoimmune disease, never miss it. The next one is, and this is completely off label, but keep an eye out in literature for restless leg syndrome treatments. Those are things that can be considered, and they've been studied in a vulnerable population, the elderly, for 50 years. So we're not talking about daytime use, it's just nighttime use. Vagus nerve stimulation is coming out. There were plenty of people, autoimmune disease will pick for that. I don't think people with fibromyalgia are going to necessarily go that way. And then the most important secondary to the sleep apnea is this thing we should talk about called positional cervical cord compression. This may be something people have never heard of. The best place in the world to have this test done is at Valley Medical Center in Renton. They've done
Which
over,
is like 10 minutes from my house.
yeah, Ken Rieger. I came back from a think tank on fibromyalgia, the Benson Hotel, Ray Gleason, we talked about. 2002, I was there to talk about dopamine agonists, which is a crazy, wacky idea. Jay Kranzler, who brought milnacipran through the FDA, he was there to talk about this milnacipran, and nobody had any idea. Another crazy idea that got FDA cleared. And then Andrei Krasikov, who's the head of the Canadian Paralympics. He's in Vancouver, MD, PhD, marvelous guy. He's there talking about, and again, we're just lecturing to each other, 30 of us, how if you touch the cervical spinal cord in a anesthetized rodent, the blood pressure and heart rate go up transiently. And what he was talking about is that abutment of the cervical cord, because he studies quadriplegia, leads to autonomic effects that you can measure cardiovascular-wise. I go, that's interesting. The next guy, Dan Hafez from Johns Hopkins, but neurosurgeon in Chicago, now in Milwaukee, has this very strange slide of an MRI looking at the neck and tilted back and tilted forward, and then the neutral, which I've seen plenty of those. And he's showing me the cervical spinal canal. When you bend it forward, it tends to open like a hose with a kink. It tends to open. And neutral, it looks, a little wear and tear, nothing special. And you go look back, some people, it looks like link sausage. And the disc shifts like the chiropractor said they do, and the ligaments buckle in the back. And I go, wow, happens in people with fibromyalgia sometimes. I go, oh. Now I'm the dopamine agonist guy talking about how autonomic effects fragment deep sleep. And I go, it seems to be in animals that this bumping the cord causes a sympathetic activity. This funny MRI seems to discover people that we don't even know have this. And I'm trying to treat the consequence of it with these dopamine agonists. So I come back to Seattle and I see Ken Rieger, a wonderful radiologist. I say, hey, Ken, can we do this? This funny MRI? He says, well, yeah, we could. We have a GE something or Philips or something. But there's a problem. I said, what's the problem? We won't get paid. I go, oh, well, what do you mean? Well, we'll get paid to do an MRI, but we won't get paid to take the coil apart, pull them out, do pillows, move them in this position, put them back in for a picture, pull them out, move them in another position, put them back in for a picture. That's about 12 more minutes in a multi-million-dollar machine. So my answer as a rheumatologist is, well, can we do like one person? Can we do one? And he said, sure, we can do one. We just won't tell the insurance that we're doing this extra work. Well, 3,000 later, we published this in the Journal of Pain, that 70% of patients with fibromyalgia has this phenomenon that Krasikov was talking about that was originally described by Don Resnick, a very famous radiologist, in 1998 at UCSD. So it's his idea. So don't argue with me. It's Don Resnick. He's a famous guy. I have his textbook on my shelf. And we go, oh my gosh. And then it turned out that the treatments, again, we're all off label here. I'm just talking to patients. The treatments we were using for restless leg syndrome, which we thought would help facilitate sleep by not having you wake up with kick in the covers, just we thought let you sleep. That was the idea. That we were completely wrong on that. It was helping for a different reason. Krasikov says, you realize those two drugs are the only two that we use for spinal cord injury pain? Oh?
Which two are these?
Well, again, this is completely off label. So
just curiosity.
But it's lorazepam and clonazepam at low doses at bedtime. Not high dose, low dose, no daytime, just bedtime. He says, you're treating spinal cord irritation. I go, well, with the MRI, it looks like we are. And it's having an autonomic benefit, which then facilitates sleep, which is helping the fibromyalgia patients. So we worry about fibromyalgia being a three-headed beast. Sleep deprivation, autonomic arousal, spinal cord bumping, pretty bumping it. And also, you can't see it in the neutral view. So that publication, 2007, and people just look me up on Journal Pain, Holman, AJ, 2007. And they get the paper. It's kind of a funny thing. They put the pictures, these fancy pictures, on the cover of the Journal of Pain. It's not the cover of the Rolling Stone, but it's the best a rheumatologist could probably hope for. Right? So again, I'm following the rehab doctors, I'm following the sleep experts, I'm neurology, neurosurgery, and then this brilliant Sue Horton, and she's like up in Mill Creek area, studies hypermobility. I've worked with her for years. She comes up with this PT program. I said, Sue, how are you supposed to make a tube bigger? I mean, it's got to be bigger. She goes, I remember her. She says, give me a chance, doc. I can do it. I maybe see what I can do it. I go, okay, Sue. So she used Feldenkrais and some other postural awareness stuff. We have it on a disc. It's for free. Any PT can do it. It was a master stroke in better PT. So you control the cord. First of all, you figure out what you got. You have to do the MRI. And it has to be a flexion extension cervical spine MRI, which they can do around the country anywhere. And then you have to know how bad it is, and somebody has to tell you. Because if it's so bad, it does need surgery about 10% of the time. There are people walking around who really could benefit, and no one will take care of them because they don't see the right picture. And if you show the right picture to the neurosurgeon, they don't hesitate for a second because they know 4 millimeters is way too narrow when you're supposed to be 13, right?
Yeah.
That's
So they
not
go in
normal.
and make the hole bigger?
They help the disc and the ligament, and they make room, and so you don't bump your cord anymore. It's carpentry. But I mean, it's not insignificant, but the idea is it has physiologic impact on the autonomic nervous system, which takes us back. And then, of course, the next generation HRV and all that kind of stuff, measuring autonomic. If you're out of kilter, you say, well, why? Is it sleep apnea? Well, that's been published. Is it the cervical cord? Yeah. We actually had a study where we looked at patients with fibromyalgia. We did not know if they had the cord. We did the next generation HRV on them. We call this cloud HRV. And in this study, we were able to show in the first time in human beings, as opposed to little mice, that bumping your cord in fibromyalgia was a potent sympathetic arousal. And there was no other physical clue that could sort out fibromyalgia alone versus fibromyalgia with the cord.
Like they looked
Nothing I could
identical.
do. Physical exam, neuro exam, anything. Just the HRV. And the MRI, of course. And then the last thing I just want to share, so your audience, because they know that Fred Wolf, God bless him, he passed on. He worked very hard on fibromyalgia for years, but he really changed the thinking to say tender pain areas and all that. It was mostly for research. I wasn't a big fan. Allodynia, tenderness to touch, is the hallmark of fibromyalgia, not pain everywhere. Pain everywhere comes with it, but it's got to be tender. If it's not tender, make your doctor look around because you have to broaden your differential diagnosis. And one of them is spinal cord compression without fibromyalgia. We've seen that too. So the bottom line is it's about best diagnostics, the best insight you can get to understand who are you talking to? Who are you talking to autonomically? What's their neck like? They don't like hairdresser sinks and things like that. They don't like bicycles with their neck up. They don't like reading glasses, look at the computer. But the hairdresser sink's the best one. It's still only 7 out of 10 tell us what they think they're going to say. So no test, no question is perfect, but the MRI is really good. So there's a lot of hope for people if they really think about this as fix the sleep, fix the autonomic, lots of choices there, quantify things, get some real data, who are you, and then don't forget about the cervical cord. It's the aging of an injury. Could have happened 30 years ago. Could have fell out of a tree when you're in high school. Doesn't matter. It's the aging of this disc moving and the ligament behind it.
That's so fascinating. It's really interesting talking to you because a lot of the studies and the research that you're talking about are things I'm familiar with, but putting them together in the sequence, like you were talking about when y'all are in the think tank going, A, B, C, here we are.
I know, yeah. Trust me, there were another 20 lectures that didn't turn out so good. Very thoughtful, very creative, very dedicated, but they, not everything works out. I'm just giving you the highlight reel. These are the things that turned out to be, oh my goodness gracious, moments.
That's amazing. That's amazing. So if somebody wanted to start measuring their HRV, obviously we've got our Apple Watches and things we can do at home. But if somebody wants the cloud HRV,
yeah, I'm afraid they have to wait till May. We'll be having them in the Northwest first. There is one right now in Florida with Dr. Norman Galis. So insurance pays for it. There's one in Grand Rapids, Michigan with Dr. Andrew Lewandowski. These are rheumatologists. Patrick Wood has one of all places in Lincoln City doing primary care. And then the other two are in Seattle with Dr. Rich Jimenez and Jeff Peterson and Dr. Bunin in Bellevue. So again, generally the insurance pays for it. It's 5 minutes, non-invasive. It is available. But to have it more widespread, this is something that we're just trying very hard to do what we need to raise the funds to, get them out there. And then the other thing, just so people know, I designed this company so that it really would support research. That's a big emphasis when we get off our feet, really get on our feet and all that. We want to make sure that we're part of finding answers, and we're not afraid to find that we're wrong sometimes too. But we need to know, so we're not relying on grants and those types of things because we're very innovative, and this is not what comes across most of the application tables at NIH and so forth. This is, they're extremely dedicated, but this is very innovative thinking.
Yeah, but that's where the fun stuff is.
Well, I tell people you find answers in strange places. I mean,
That's right.
and again, patients tell you stuff. There's got to be a reason for that. Yeah.
Yeah, even if it's just random, they're all clues.
Nobody thought a bacteria could cause stomach ulcers. Turned out to be true, right? And one of ours, we saved one for Britt Adler. She's a wonderful rheumatologist at Johns Hopkins. She wanted to explore in the chronic Lyme disease clinic there, which is world famous. And as you know, in Seattle, we don't have Lyme disease. We don't have the right tick. So I've actually never seen a case, even though it's on my board exam. But she's thinking that chronic Lyme, long COVID, fibromyalgia, chronic fatigue, what they have in common is the autonomic nervous system is upside down. And so she wanted to look into that with chronic Lyme. And I said, okay, we'll save one of the 6. We only have 6. We're going to give one to you at Johns Hopkins. So it's in the chronic Lyme disease research center.
Very cool. Very cool.
I wish her all the luck in the world because that's a tough one.
Yes, it
People
is.
are still banging on the drum that it's untreated infection. It may be an autonomic consequence that may be treated a completely different way. And we have long COVID data with Dr. Galis in Florida. He's a world expert on long COVID as a rheumatologist in Aventura, Florida. He's got 2 abstracts at the American College of Rheumatology meeting on long COVID with this more advanced HRV. I have no doubt he's going to come up with solutions too.
That's awesome. So, as we wrap up, thinking about all of our fibromyalgia listeners right now, what would you recommend, like some of their next steps might be after hearing all this good information?
You know what would be nice is maybe I can furnish information for you, maybe a slide or something where they can go to some papers and get them to take them to their doctor.
That would be awesome. Yeah, we can totally do that.
Can't really talk that very well, but just that's what we do when people reach out to me. They realize I can't give them personal advice over the internet, but I can say, here's the principles and here's the papers to talk to your doctors. And in this country, doctors are allowed to talk to each other state by state, even without HIPAA stuff. So doctors can reach out to each other.
Yeah, that would be amazing. That would be awesome. We can put that in today's show notes where people can maybe go out and download it and take it to their doctors.
Yeah, exactly. And so, and I wish I could tell you, boy, I wish it was as available as your Apple Watch. This has to go through FDA. It's a completely different pathway. And we're a little, innovative group of science nerds out of Seattle. And so we're just picking up steam now, but you're right. We have a big job to do and we're ready to do it. Thing out there to everybody.
Meanwhile, things like our Apple Watch are not totally useless.
No, of course not. What you'll notice is they compare you to you.
Exactly.
That's what mine Whoop does. And so try to keep optimizing. Take care of yourself. When it says you need more sleep, you have sleep deficit, you do. You do. Find a physician who cares. They don't have to be a world expert. They just need to care and listen and maybe read some of those papers and maybe contact the author. They shouldn't feel guilty. Doctors feel guilty that they don't know how to answer your question. And I remind them, don't feel guilty. This is highly specialized information. And also patients, I think they know, and you know too, medicine is hard. It's hard. This is very hard. There's no doctor I know who wants to be a poor physician. And when they learn some of these ideas and tricks, they're just usually elated to see the smiles on their patients' faces when we start to make progress, even if it's incremental. If you meet grumpy people, I have no patience for them either, doctors, but find somebody who cares. That's the most important. They will try hard.
That's right.
Starts with effort. And don't take no for an answer.
Yeah, I feel such compassion for our doctors because you have to know so many things. Like, I just can't even imagine how one person could possibly know everything about everything. There's just too much. but that treating you like a decent human being would, right? Believing you when you say something and having that compassion for you, like those we can expect for sure.
I feel like I have an extra PhD in fibromyalgia, but it took 4 new patients a day and 10 follow-ups for 20 years.
Yeah.
That was a lot of people.
That's a lot of people.
I was talking in my sleep and all kinds of stuff. I didn't know what to do. It was the 90s. You would have laughed. This young doctor guy, I don't know what to do. But I didn't turn people away. I remember having conversations like, I really don't know what to do. But I want to see in 4 months because I keep going to meetings. I keep reading. In 4 months, I want to report to you what I've learned. If it's that 4 months, it'll be the next 4 months. That's what I told them. At least they knew I wasn't going anywhere. Martinez Levine comes out with a paper on Mexico City. Moldavsky comes out with a paper. The spinal cord thing, the think tank. I go, I think there's a pathway here. I couldn't cure everybody, but we definitely saw a lot of progress. The fibromyalgia knowledge of autonomics has a huge education and application in autoimmune disease.
Yes.
Every MS patient will tell you that stress flares their disease. Lupus the same. Rheumatoid arthritis the same. We've asked them. We need to understand immunoautonomics. Thank you to the fibromyalgia patients who never gave up to let us figure that autonomic stuff out. And now let's get them fixed too. So.
Yes. If we inspired this, we should benefit a little.
I'm not exaggerating. It wouldn't have happened without that effort.
That's awesome.
Wouldn't have happened.
Thank you again so much for all your many years and many seeing patients, just for your care for our community. Like, it's such an honor to have you here because you've given so much to us. But also, thank you for this new thing. This is great. And sharing your knowledge with us is awesome.
Thanks for the opportunity. It's a treat for me. I just appreciate what you're doing to try to spread information, try to get people some help.
Absolutely. Absolutely. And for you listening, hang on. I have a couple extra resources I'm going to share with you and a couple other episodes that touch on some of the topics like sleep that we've just talked about. So stay tuned. I'll have all of those in just a minute. And that wraps up my conversation with Dr. Andrew Holman, board-certified rheumatologist and co-founder of InMedics, the company behind Cloud HRV, an FDA-cleared technology that measures autonomic nervous system activity through heart rate variability in just 5 minutes in a clinical setting. As I mentioned at the beginning of this episode, Dr. Holman has put together a list of resources you can share with your healthcare providers. To request your copy, visit today's show notes at fibromyalgiapodcast.com/175, and we'll email a copy of that to you. I also want to point you to a few additional resources if you'd like to go deeper into any of the topics we discussed today. First, and this is so important, as Dr. Holman emphasized, never miss sleep apnea. About 45% of people with fibromyalgia have sleep apnea, so it's nearly a coin flip. In the general population, it's less than 10, and in women, less than 5, which means many doctors may not realize just how relevant this is for those of us with fibromyalgia. This is why I recommend that my students and my clients all have a sleep study. If you haven't had one, or if it's been several years, it's worth having a conversation with your doctor about why this matters for you. If you'd like to learn more about fibromyalgia and sleep, you'll find a curated list of podcast episodes, Fibro Compass articles, and a book chapter in today's show notes at fibromyalgiapodcast.com/175. For nervous system regulation, I've also included links to a few articles written by our coaches, along with a related podcast episode. Again, you'll find all of that in today's show notes. As I mentioned in my conversation with Dr. Holman, I personally use HRV and sleeping heart rate, and I teach my students and clients how to use them to better understand pacing and fibro symptom management. These tools can really help you recognize when you may be doing too much or when your body might tolerate just a little more, gently, of course. And if you'd like to learn more about my training programs where I teach all of this, you can visit bafibrocoach.com. That's B, the word B, B-E, bafibrocoach.com. Even if you don't want to become a coach and you're simply a patient who just wants to feel better, you'll find programs there designed to support that goal. This really is a next level approach to helping your fibro symptoms. This idea of using HRV and even sleeping heart rate, it can really help improve your pain, energy, brain fog, and sleep. Now it is time for this week's listener shout out. I received this sweet note from Debbie who wrote, with so many questions on our search for our own unique way of navigating fibromyalgia, you truly are a very valuable guide, Tammy. I feel so much better because of your podcasts. Thank you so much. And thank you so much for this too, Debbie. I am just thrilled that the podcast has been helpful for you. And Debbie really makes such an important point here. We all have to find our own way of navigating our fibromyalgia. Having a guide can make that process faster and easier. Whether that guide is data, like your HRV, whether it's this podcast, our Fibro Compass, our YouTube channel, or even working one-on-one with a coach. This really is a choose your own adventure kind of story. Whether you prefer to read, to listen, to watch, if you want to just do it yourself, or if you want that personalized support one-on-one, the options are all there for you. You can find all of our resources at fibromyalgiapodcast.com. Click on resources in the main menu. And if you'd like to work with a coach, honestly, I recommend scheduling sooner rather than later. Our coaches do tend to fill up quickly, especially at the beginning of the new year. Everybody wants to kick the new year off right. So to schedule with a coach, you can just visit findafibrocoach.com to get started. You'll also find that under that resources menu. Thank you so much for being here with me today. Take good care of yourself, and I will see you back here next time. And that wraps up another episode of the Fibromyalgia Podcast. I'm your coach, Tammy Stacklehouse. For daily doses of hope, inspiration, and practical advice, come hang out with me on Facebook. Visit facebook.com/fibrocoach to find my personal coaching page and connect with me directly. To find the show notes, additional resources, or to schedule a consultation with me or one of my coaches, visit fibromyalgiapodcast.com.